Hi, I'm Dr. Subramani, one of the anesthesiologists at the University of Iowa, United States. In continuation of this RIA education curriculums, I'm going to talk about echocardiographic assessment for Mitraclip. I know in India, the Mitraclip started performing in certain centers. So eventually more centers going to do that. So just to give a brief update on utilization of echocardiography in this procedure. I have nothing to disclose relevant to this topic. Just to primarily try to understand the major steps in the Mitraclip and to determine the role of echocardiography in this procedure, and then eventually we can identify certain common problems immediately after the deployment of the clip, as well as the later complications. So before I go in depth, I would like to throw a few scenarios and try to figure out whether the listeners are familiar prior to review these presentations. The first thing come to your mind is which is not correct when you have this echocardiographic criteria for a mitral clip, whether the length less than 11 millimeter or the gap more than 10 millimeter, or if the depth is less than 2 or the width is less than 15. The most suitable anatomy for the mitral clip, the one with moderate to severe mitral stenosis or having a cleft in the anterior leaflet, or if you have just the dilated annulus, or if the leaflet in the posterior side is less than 10 millimeter. An ideal location for transseptal puncture. For degenerative, it is more on superior posterior, or a functional more of superior anterior, or for degenerative more of inferior anterior or inferior posterior. So move on to the background why this clip idea has been started. If we look at this historically, the mitral clip has been based on the surgical repair, which is kind of the all-ferry repair where they try to put a stitch right around the center of the annulus so that they can shrink it and minimizes the regurgitation. That's what, in kind of patients who cannot tolerate long bypass, or it's very hard to resect completely and then redo it, those situations they try to do it. So the same thing they're trying to do percutaneously, utilizing this such kind of a delivery system where you have such a long clip delivery system with the guided wire, and then the device is right at the end of the clip. Potential indications, like in TAVR, the indications keep changing, especially in the last few years. So historically, it started with moderate to severe MR, predominantly for a degenerative type, and then eventually they expanded to even a functional MR. And those who are having a high NYHA 3 or 4, despite of medical therapy, they are pretty hard to control the symptoms, then maybe they are favorable. And then if the favorable anatomy for repair is also favorable for mitral clip. And the most important thing is somebody has to live at least for 2 years. Otherwise, it's not worthwhile attempting these procedures. So if you look at this, these are the potential indications in relation to the clip. Like any other procedures, whenever we try to look for indications, it's always essential to look for what are the potential contraindications where they can't, tolerate the procedure. So those who are with having, significant anticoagulated, and then, if there is any, they cannot tolerate the antiplatelet regime, then probably you may not even consider these procedures. And then one with active infections going around the valve, the mitral stenosis because of the rheumatism, which is very common in India. But as I said, the indications are slowly expanding. They try to do once in a while, but there's not enough data on this. But at this moment, it is more like a relative contraindication. And if you have a solid evidence of any clots, thrombus sitting in any of the chamber, then again, you don't want to do it. In terms of echo role, it's like broadly come under 3 areas: pre-procedural, during the procedural, and as well as the immediate and delayed complications. So in terms of pre-procedural, the main thing come to your mind is it's like no difference from determining, how bad the severity of the disorder, and then how big the annulus is, if it's more like a dynamic structure or if any distortion, and also how the leaflets are kind of figure it out, like, whether it is causing any tethering or, significant changes in terms of the depth and stuff. Those things will help us whether the procedure is going to be easy to do it or not. In terms of remodeling wise, if there is any significant geometrical changes in the LV, then it's going to be more challenging in certain situations. And ultimately, you want to assess the overall suitability of the anatomy. So pretty much extensive assessment using an echo, and of course the 3D and as well as the CT constructions are all really helping, and even go behind MRI, dynamic images are also being utilized for certain scenarios. So it's pretty much there's a significant role in terms of pre-procedural assessment. So first thing you always start with obviously the, as I mentioned, that geometry of the LV, how big and whether the annulus is like kind of just dilated. In this case, if you look at this, the MR is more going towards the one side. It's more like an eccentric jet. But then again, you have to look at the other views, kind of 4-chamber where you have a long axis, and then of course the 2 chambers. The multiple views, you try to get that early assessment and try to figure out the nature of the MR. And then if you can use the 3Ds, as you can see on the left side without color, and then with the color, it's even going to delineate both from the atrial side as well as from the ventricle side. That's kind of where the 3D comes. And then moving forward, it's kind of where the close look again for the 3D with the color. It's going to compromise your frame rate, but at the same time, you can get a clear picture of, exactly delineate the orifice. We can even calculate the effective orifice, with more like a central versus the eccentric.